Hello, everybody. This is Dr. Al Hewer. I am Terry's partner in A&T Lectures. I also teach at Rutgers in beautiful downtown Newark, New Jersey, which is about 20 miles west of New York City. And again, following suit with our theme on sleep topics, this particular presentation is entitled "The Toolbox for Improving Adherence to Non-Invasive Positive Pressure in Sleep Disorders." Let's take a look at some of the actual learning objectives. So over the next, 50 minutes, give or take or so, we're going to review statistics related to positive airway pressure, PAP, and obstructive sleep apnea. And again, the obstructive sleep apnea is really the main focus of this presentation. We'll discuss ways to monitor adherence to positive airway pressure, evaluate some of the barriers, which is really the crux of this. There's categories of barriers that result in less than optimal compliance on patients' parts. And yes, it's our job to help increase their compliance, because we know that there's so many potential ramifications of not being compliant or not even diagnosing, basically not treating obstructive sleep apnea. We will provide additional resources for those who want to drill down on these topics as well. So studies show that patients having obstructive sleep apnea typically go undiagnosed for up to 10 years with steadily increased use of healthcare resources. So again, the aforementioned some of the consequences, such as daytime sleepiness and neuropsychological, just basically being less attentive, less productive, we've known about. Now, those are certainly issues, but these other comorbidities, such as diabetes, hypertension, heart disease, stroke, we definitely know that there's a much stronger predilection that individuals will have, the greater risk for these sorts of disorders if they have or undertreated obstructive sleep apnea. So it's a big deal. And when you consider that folks go undiagnosed for 10 years, up to 10 years, it means that these conditions were developing over a period of time, and it could have been averted if we had, basically found out there was a problem and intervened sooner. A little more on the facts. So OSA occurs in an estimated 5% of the adult population. I will tell you this, that there's some studies that are suggestive that it's actually more than that, okay? But it was saying a minimum of about 5%, about 1 in 20 in the adult population. CPAP is the first line. It's been the first line for 40 years or more, still is. It doesn't mean that there's not these other therapies out there that I'll allude to in this presentation, but it very much is the first line to treat moderate to severe obstructive sleep apnea. CPAP is almost 100% effective when it's used regularly, but adherence to it is a challenge. Just picture this. So if your settings are, let's say you're on BiPAP, you're not even on CPAP, and you're on, 16/8 or 14/8, something along those lines. The flow to achieve, okay, that pressure of 14, or if it's CPAP, the flow to achieve a CPAP of 10 or 12 can be 60, 80, 100 liters a minute. Okay, so it's no wonder you could use CPAP if you could heat it up a little bit. You could use it to dry your hair. I don't have much hair, so I really don't have that problem. But you get the idea. No wonder that individuals find it challenging to to basically adhere to this therapy that can be kind of difficult to take. When you couple that with maybe the gas is dry because it's not humidified, at least yet, and the interface, the mask that's used may be one of the cheaper masks that's uncomfortable. That's a lot to bear with. Then you got a hose. They have these commercials out now where they have these, support groups for obstructive sleep apnea patients, etc. But it's saying it's a lot to deal with. But it's also, the benefits are there as well. So it's a matter of trying to get over some of those hurdles and working through it. Provision of CPAP involves more than simply selling the CPAP device and the mask, and they seem really obvious, but certainly it applies. It's first identifying the patient, the high-risk patient, the education, the monitoring, the initial setup, the ongoing support and follow-up are all critically important. This is often a shared responsibility. I would say it is a shared responsibility. The patient owns some of the responsibility for giving it an earnest effort, for paying attention during the instructional sessions, for reading the additional materials that are furnished via websites and hard copy material, etc. But it's not all up to them. The sleep physician, often a pulmonologist, the sleep clinic, so that, basically the respiratory therapist or the polysomnographer that's actually, in the sleep lab or is in other ways supporting the individual. The equipment provider is key as well. So they own a certain amount of, not literally and figuratively, a certain amount of the patient's success as well. So this is clearly a shared responsibility. CPAP adherence. Adherence refers to the degree that an individual follows a recommended illness-related, sets of recommendations. So, it could be a diabetic, following the plan there. It could be a patient who's got heart disease, and cutting down on fats and salts, and you get the idea. But adherence means we have the treatment plan, or you're following it. Okay. Adherence failure in the context of CPAP, use of CPAP for less than 4 hours per night, 70% of the nights, and or lack of symptomatic improvement. 5 to 50% of OSA patients reject CPAP within the first week. So that's the bad news. The good news is, so flipping this around, the corollary to that is if we can get them through that first week, and I'll share some specific strategies with you along those lines, some of which are just not theoretical. When I was doing home care, we knew that if we could get them to try it gradually and build them up over a first week or two, that we were successful probably 75% of the time, 70-something% of the time. 12 to 25% of the remaining patients often discontinue to use at 3 years. So what happens is the non-compliance is at a minimum, when I say bifurcated, there's two, if you will, tranches. One of them is up front. One of the big challenges is up front. So getting that 5 to 50%, but let's just argue and say a third, 30-something% of the people, that getting that third of the individuals to try it beyond that week. Okay. And then getting the individuals who now are feeling all the relief, but they don't really want the hose, they don't want this, pain in the ass to clean it, and to get the ones that at 2, 3, 4, 5 years say, I'm feeling fine. Almost like the psych patient that says, I feel really good, I'm going to come off my medications, and then they're not really good anymore. So you can just see that there's at least two vulnerable points in time that really need to be focused upon. Benefits of CPAP adherence. So CPAP reduces daytime sleepiness, depression, cardiovascular, morbidity, mortality, accidents, and then the whole diabetes, the thing that we would superimpose on top of that. Improves some of the measures of cognitive performance. Again, talked about really, it's the accuracy, not so much the speed, but it's also the administrative, it's being able to organize one's life, both professionally and personally. Reduces healthcare utilization big time. Adherence to CPAP treatment is the largest factor impacting the effectiveness of OSA treatment. So it's really, if we can get patients more compliant with the CPAP, then you're not hitting everybody, but you're hitting a lot of the folks that are afflicted, and you're making them feel better, you're making them more productive, and you're making them less apt to unnecessarily utilize health services. Basic requirements. What do we need to get these patients, set up and compliant? A staff who are appropriately trained and educated. Depending upon what state you're in, in New Jersey, we do have separate licensure for polysomnographers. I'm not saying that's good or bad or whatever the case may be, but I was very active in our state Society for Respiratory Care, and it was kind of more contentious than it should have been, because, there was a time when CPAP and BiPAP were being set up by nursing assistants and medical assistants and that sort of thing. We've at least gotten away from that in large part. A choice of CPAP equipment which meet the individual patient needs. And that may be, easier said than done, it may be the mask that's not necessarily the cheapest. It may be the one that's most comfortable and it's easiest to clean, and you get the ideas, but it works on multiple fronts. Obviously, it's one that's fully functional, allows the patient to get rid of the CO2, etc. CPAP initiation service, which provides patients with adequate information, education, and follow-up. Follow-up's a challenge for this reason, is that reimbursement has constantly been cut. reimbursement for, CPAP, BiPAP, oxygen devices, et cetera, et cetera. So the follow-up is probably not what it was a long time ago. Some of it's been digitized, okay, and some of it is text message, some of it is follow-up emails. You get the idea, maybe it's an automated phone call. If you got an issue, press this, you may get a live person. Right? You get a live person within, X number of hours. If it's an emergency, call 911, but if it's not, you'll get a call back. Those sorts of automations can be done, but it is difficult. Again, we used to follow up fairly frequently, at least with phone calls, and then if they were having difficulty, come out, and then beyond that, go out, change filters, make sure that if it had a humidifier, that it was being cleaned, there weren't sea monkeys doing the backstroke in the reservoir for the humidifier, et cetera. An infrastructure that enables timely and efficient communication with sleep clinics and referring doctors about their patients. So it's this interprofessional communication and collaboration, which we know is at the heart of a lot of healthcare errors and problems, but thankfully is also at the heart of, optimizing. If it's done well, if that collaboration and communication is done well, that it can be a very big plus. Assessment of CPAP adherence. To assess CPAP adherence and treatment efficacy, CPAP manufacturers have implemented tracking systems. Okay, and this is not new, by the way, but it was not in place when I did it. It was probably in its infancy. We had a recording device that could be downloaded, et cetera, the compliance, et cetera. But it was shortly thereafter when we initially had like modems, dial-up modems and things like that. And now it's really, a lot of it's through like telehealth and that sort of thing, that where it's actually tracked. You monitor how often, and for how long the patient's actually using it. So residual sleep disordered breathing, hours of CPAP or BiPAP use, the mass leak, and kind of important but rudimentary findings. CPAP adherence tracking is now the requirement for Medicare and a lot of the other private insurance companies for reimbursement. So if the patient's not compliant, they're given a little attitude. There's follow-up. There's like, what's going on here? But at some point, if the patient's not compliant, they'll take the equipment back and, it'll go back to the supplier. Several different methods to transmit CPAP adherence tracking data. I just gave you one. It's just a thumb drive that fits in. It transmits data, but there's a lot of other, ways this is going on as well. Most systems use cards, smart cards, SD cards, memory sticks, lions and tigers and bears am I. The CPAP adherence profiles are not standardized between different manufacturers. And the reports are not yet easily exportable to certain, electronic medical records, et cetera. That's changing as we speak. But I'll kind of say that it's an evolutionary process. USB smart. I'm just giving you an example. I'm not. This is a Fisher Paykel, but I'm not saying that they're better than Philips Respironics, as much difficulty as they're having. But you get the idea that USB Smart Stick card is designed for use with Fisher Paykel. Smart Stick works, and again, I'm not pushing this. I'm just giving you an example. Works as a miniature USB drive capable of transferring therapy data from a smart stick without the need for separate, card reader, et cetera. To review data on the card software like Fisher Paykel's performance maximize. So it's really required. It's one of the things. It doesn't have to be this particular form of technology, but some way of monitoring it so that you can actually see, is the patient compliant? If they're not, can we find out why? And then after trying to address all those factors, they're still not compliant, let's take the equipment back. So barriers, and let's look at some of the barriers and how they're actually categorized. So you have patient-related, you have therapy-related, and these, by the way, this diagram infers they're all separate. Let's face it, the patient-related and the clinician-related are probably overlapping, okay? The equipment-related and the clinician-related, you have the right equipment and the clinician didn't do the good job educating, and, you could have all, you get the idea. So there's clearly some overlap. This diagram, though, is just to kind of show you that there are these categories: patient-related, clinician-related, equipment, and then therapy-related also. Equipment-related, complexity of the therapeutic device. A lot of this stuff today, a lot of the CPAP and BiPAP machines are pretty intuitive. They're not designed to be easily adjusted by the patient, okay? But as far as to turn it on, turn it off, change, it's pretty straightforward. Excessive mask leak, can be identified as well, and it would be something that would need to be addressed. Portable battery backup is pretty common. A lot of these devices, they're becoming cheaper and smaller and battery powered, etc. Device noise, they tend to be pretty low, low noise producing as a requisite. The hose length, typically they're 6 feet. Can you get more than that? Fine. But then it's improper mask fit or improper interface, improper mask, improper nasal pillows. Okay. So the big equipment related barriers. The other one that we'll talk about a little bit later on, but is also humidification. And if it's too dry, having a humidifier, built-in humidifier is becoming the standard of care because it's been recognized that even if the patient's not complaining, it's better that it be humidified as long as the humidifier is being maintained and is being cleaned out along with everything else, the mask, the hose, the headgear, etc. Therapy-related barriers, so adverse reactions that go unaddressed. Nasal dryness. So, like I said, equipment also can relate to the actual therapy itself. So they're overlapping here. Nasal dryness or dry eyes. Nasal congestion. So, someone can develop, nasal dryness, but then the body may actually be maybe irritating. So now the patient has, if you will, clogged sinuses or clogged nares, which can render the therapy, depending upon, if they have a full face mask or a nasal interface, can render it not usable or not effective. Skin irritation, a reaction to the whatever substance the interface is made out of, whatever, or it's too tight. Again, it's not common in a home setting that the patient develops facial breakdown, but it can happen. And certainly in a hospital setting, it's considered a medical error now. The bloody nose would be more response to the dryness more than any sort of trauma from the mask, etc. It doesn't mean it couldn't happen. It doesn't mean the patient could roll over. They had a mask on. It did something with a vessel in their nose and it's bleeding. But most of the time, it's really because of dryness. The expense of the therapy. So that by definition, if the coverage is through Medicare, the patient really does need to be, by law, needs to be billed for the 20% copay. All right, they need to be billed for it. There can be negotiation between the home care company and the individual as to whether or not they actually end up paying that 20%. But what they don't want is the individual choosing a home care company because they were coerced because that home care company said, we'll waive the copayment. The bill needs to go out. Okay. And then whatever happens from there within reason, is a different story. Governmental policy, so reimbursement, licenses of clinicians, and, the drivers that are actually delivering this stuff. So it's more, in the day. I know we're talking about CPAP and BiPAP mainly in this presentation, but when I was doing home care, they were just in New Jersey, they were just traversing from respiratory therapists having to do the initial setup for oxygen therapy. I'm thinking on call, Sunday night, 11 o'clock at night. If you were on call, you might have to go up and set up oxygen. The laws changed about that time where the driver could go out and set it up initially, as long as a respiratory therapist contacted the patient, and then went out there within 48 hours to make sure that they were using it properly. So drivers are an issue. They're licensed to drive, to physically drive the truck or the car. But we're talking about, they are allowed to do certain things, okay, beyond just delivering the equipment in certain states. Just want to be clear on that. And then the whole issue of adherence, oddly, again, it decreases over time. It's not like it decreases in month 2, okay? Because if the patient's been, 8 out of 10 of the patients, if they've been compliant, are able to use it, they're probably starting to feel better, okay? So adherence decreases over time. You got that 3-year-ish period. Nasal pillows, I'm showing you one example here, but there with nasal pillows, typically the tubing or the circuit will go over the top of the head. And some of the patients find it less, particularly ones, I'll talk about claustrophobia, because that is an issue for 10 or 15% of the patients, maybe a little bit higher than that. And nasal pillows is one way to help address that. There are individuals that find nasal pillows much more tolerable than a nasal mask or a hybrid mask. that, it's both the mouth and the nose type of deal. The nasal mask, this is showing you kind of one of the older style nasal masks with the headgear. Again, this particular setup is with the exhalation port pointing up, which suggests that the circuit is going to go over the top of the patient's head, or it could be pointing down, and it's just going to go this to the side of the patient while they're sleeping. Patient can either exhale CO2 through their mouth in this case, but there's also probably a vent right in that elbow there that allows them to also eliminate CO2. With these type of masks, again, devil's in the details. I would almost need to kind of pick it up and feel the material. And, some home care companies are really using the kind of more expensive ones because the patient will be more compliant. So it's more of like this gel pad material, or this softer latex, assuming the patient doesn't have a latex allergy, which certainly might want to be something. And something where some of the pressure that's imposed on the patient's face is also taken by the forehead as well. And this is just a full face mask. The thing with the full face mask is you just got to watch with vomiting, issues like that. We have a policy. I realize we're talking mainly in a home setting, but in the hospital, none of the patients that have full face masks can have any sort of restraints on. Just, whether they're in the ICU or they're on the floors, etc. But this is, the full face mask would be. The problem with a nasal device is that you can lose a lot of the pressure right through the mouth if the mouth starts opening up. So, full face mask can have the disadvantage of the patient vomits. It could be a catastrophic event, but also you don't have the issues with, any of the, if the mouth opens up, they're still covered, if you will. Full face mask, or the hockey mask. Some patients find this comfortable. Some find it too, if you will, confining, if you will. But what you're doing is you're taking the pressure that's on the patient's face and you're spreading it out over a greater surface area. So much less likely to incur any sort of facial breakdown in the bridge of the nose, etc. Well, it's not going to be the bridge of the nose, but I guess it could be the forehead. So these are more expensive, but they're better tolerated by some patients, with the caveat that if the patient's nauseous, etc., it can be an issue. Obviously, they can't eat with this. So, and there are patients who they're starting to improve. They're still not quite ready to come off the BiPAP or the CPAP, but whatever. But these full face masks. This form is not commonly used in a home care setting. I included it more for the sake of completeness. So now we're into patient-related barriers. And again, these may overlap with some of the dryness. So you could say the dryness, the patient doesn't want to use it. Is it a patient problem? Is it an equipment problem? Is it, so there's overlap here as well. Health literacy really has to do with people understanding, if you will, understanding wellness and things they need to eat right. They need not to smoke, to watch their drinking, to drink the right amount of non-caffeinated, non-alcoholic stuff so that they're properly hydrated, but not drinking excessive alcohol, caffeinated beverages, sodas, things that don't really hydrate you as well. So health literacy is being aware of that stuff. Okay. It is in part our responsibility as clinicians when it comes to this slice of the pie, the CPAP, BiPAP, OSA slice of the pie, for enhancing their health literacy in this area by educating them on what's going on with the body. Almost like, prior lectures of mine, other lectures of mine, we talk about what's happening with obstructive sleep apnea, and the upper airway muscles and the tongue and the uvula are relaxing and are causing the obstruction, etc. So it's really, and then how does a positive pressure improve that? Okay, and then what are the ramifications of successfully using the CPAP or the BiPAP to overcome not just the OSA, but the concomitant, risk for diabetes, heart disease, stroke, etc. So the health literacy is something that's patient related, but it's also, we play the role in helping enhance that, at least as it pertains to the OSA and the CPAP. Ambivalence is, I don't see the benefit to this. So that's where the education say, well, let me try to show you some of the benefits. And this is not the benefits according to what I think. These are the benefits in accordance with what is the truth, okay, what's been shown in research studies. The lack of family or social support. And, some of that is, it may be a bed perceptions that the bed partner may find that the individual thinks that the bed partner is going to find the CPAP or BiPAP obtrusive. Okay, and I'm not saying it's not, guys. I'm not saying it's not at all. But what's been found is many times if the patient thinks that, many times the bed partner is not aware and is like, listen, if this makes my husband, my wife, my bed partner, my feel better and have better health, I'm fully supportive, completely supportive. So it's more the patient than the actual bed partner. And then, again, that would go with other forms of social support. It may be in the form of literally a support group. Okay. That, this patient's having trouble, being compliant. They find it uncomfortable and whatever. And they're not quite at the point where we want to try upper airway stimulation, et cetera, because they don't have a lot of comorbidities. And maybe connecting them with some of the support group from people who have overcome some of those things can be very helpful to them. Patient economics. If I have a copay, it may be problematic. Or if I need a different mask and the company's not going to, I got to pay for it out of pocket because it's a really good mask that I like and I can tolerate it. But when I was initially given, it broke. And now I need another one. It's going to cost $189. And you may say, wow, what's $189? To some people, it's a lot of money. Lack of reimbursement. So kind of going with the patient economics on that as well. Or just, again, could be the copay. The psychological variables, the claustrophobia, which I'm going to spend a little bit of time on separately in this presentation. Physical limitations, being able to put it on. You say, well, everybody can put a headgear. Not everybody. If you have arthritic hands, if you just have poor dexterity, for whatever, if you've lost your hands in you're a military, you were a firefighter, there's things that we take for granted, but it's just, it shouldn't be. Less severe factors, little or no perceived benefit from the therapy. That's where it's our job to say, listen, not everybody's the same. Not everybody reacts the same to this, but the chances are you will realize some benefit from this. Use of prescription and non-prescription drugs or alcohol, again, really as more of a patient barrier. That if you're taking sleeping pills and they work and you fall right to sleep before you put your mask on, or you don't put it on right because you have altered mental status, then it can be problematic. Likewise with excessive alcohol use, where you're just, you're schnockered and either you fall asleep, on the couch or in the chair or whatever the case may be, and you didn't put it on or you didn't put it on right. Claustrophobia. Okay. Something that I don't, really suffer from, but I know people that have. There's a form of a specific phobia fear, that entails extreme anxiety and panic elicited by closed spaces. So think about clothes like being in a closet or a phone booth, or you think about patients that need PFTs, body plasmography, whatever. So, for some people, it's a big deal. Almost 1/3 of sleep apnea patients endure CPAP-related claustrophobia. Now, it may be I feel funky, but I've overcome it on my own. It's not a severe phobia, okay? May lead to non-compliance, but it may be if it's severe enough. So CPAP-related claustrophobia was perceived as one of the biggest deterrents to CPAP therapy. It's too confining. We're talking about somebody that actually has, a fear, a genuine fear, not I feel a little bit, I feel closed in, that we could debate that that's a mild form of claustrophobia, but that may not be a deal killer. But for patients that actually will start to panic, okay, it may absolutely be the largest deterrent to them being compliant. And to just ignore it and say, well, you got to suck it up, put on your big girl pants, big boy pants, is not sufficient. So I'm going to circle back to that, but let's just finish this to clinician-related barriers. So poor patient relationship, you just don't have a good bedside manner, or you normally do. That day you didn't, and you got off to the bad foot. Lack of clinical follow-up. Okay, yeah. So the clinician, the home care company, the sleep lab, so there needs to be a plan, a protocol to follow up with these patients. Expression of doubt concerning therapeutic potential. So if the individual, okay, if me as the educator and educating my respiratory students or sharing knowledge with you, if I'm like saying, I don't know, yeah, you'll get your CEU, that's fine, you get your CEU. But if I walk away, you guys know better. But let's just say it was a more naive audience. The professor didn't even believe in this. They were doing it because they had to do it. Or I'm not coming to you as a professor, but your colleague, he's sharing your. It's like he didn't even how am I supposed to believe in it if they don't? So there has to be a certain amount of belief, even if it's couched. Listen, This doesn't work for 100% of people, but it works for most. Okay. If we can get you to the point where you're using it, every day for 5, 6, 7 days, chances are you're going to fall asleep and you're going to think you slept for 5 minutes and you pulled the mask off and it was 5 hours. Okay. And that will happen for a lot of these patients if we can get them to that point. More to come on that. Unwillingness or inability of the clinician to educate the patient. Some people just not natural born educators. I could go on and on about that. I'm a better educator now than what I was 3 years ago, and then before that, 5 years and whatever. Could I be better next year? Probably will. Okay, so I learn things all the time, but it's not educating patients. Certain things that you could be a people person, and that's good. In education. But it doesn't make you in and of itself a good educator. So it's just like, unwillingness, inability of a clinician to educate a patient, lack of knowledge on patient's medical history and or medication the patient may be taking. I want to actually circle back, indulge me just for a moment to this, the education thing. Okay. Separately, Terry and I, we have a lot of lectures, but separately, we do a few lectures on like leadership. We do them for California, but we offer them broadly speaking. Okay. And one of the ones I recently prepared was in preceptorship for respiratory therapists. So in there, so you have respiratory students or new grads. Let's stick with the respiratory students that are precepted often by staff. Okay. And the catch with that is they shouldn't just be educated by the staff. And I'm not saying you guys haven't done that and haven't done a good job, but there's certain basic tenets that hopefully your department, okay, and or the education institution that your organization is associated with, where they have you go through kind of your own, not your own, but an educational intervention on how to precept students, how to precept new hires. And again, there's the devil's in the details on it, but what the evidence says is, and the good news is that there's a lot of materials out there. Okay. And separately from this, I know I'm getting off point here a little bit, but separately from this, there's other presentations that Terry and I do that kind of point you and your institution in that particular direction. Those same principles that we cover that I personally cover in that presentation could be applied to the second to last bullet point as well. Barrier no one wants to talk about, reimbursement. Reimbursement from CMS's Centers for Medicare and Medicaid Services and private insurance is a troubling barrier. And I'm not saying Medicare is bad, and I'm not saying private insurance is bad, but they're constantly trying to control their expenditures and their costs. Okay. Reimbursement for CPAP and BiPAP and other respiratory interventions has been cut dramatically over the past 20 years. Now you could say 25 years. Such reductions leave fewer resources for proper equipment, patient education, patient follow-up to address compliance challenges. And things like cheaper masks that are less comfortable for patients, so proper equipment. So the actual intervention, so what to do. It's really kind of the age-old question. But that's where, like other presentations I've given is here's the problem, but we also offer some remedies and suggested strategies. So equipment therapy interventions, heated humidification to relieve nasal dryness, runny nose, nosebleeds, etc. Nasal spray, it's something to try. It's not a panacea, but if the patient can actually, benefit and then they feel less dry to start with, less able to maybe pull the mask off in the first 10 minutes. CPAP modalities, the auto titrating is becoming the standard of care, where it just figures out, where that pressure needs to be. And it may be even positional. The patient turns over, the pressure needs to change. It changes, it figures it out. Or bi-level, PAP, BiPAP, where you have the higher pressure going in, lower pressure coming out. And, we're used to in a hospital setting, well, BiPAP's used to blow off CO2. But in the setting of obstructive sleep apnea, it's also used to enhance patient comfort. Is that they're getting more in, but they're having to exhale against a lower pressure, if you will. Refit the interface. So it may be the right interface. It just, we don't have it. They're not putting it on right. And we need to detect that and help them out. Change the mask type. So maybe change to nasal pillows altogether. Other comfort features of ramp where you start off at a lower CPAP or BiPAP level, and then it ramps up over 10 or 15 or 20 minutes. Quieter blower, I'm saying blower, the quieter device, battery backup, so that if there's a power outage or someone is, honestly camping, where they don't maybe have, constant power or whatever, they're taking a flight for 22 hours and they may be able to, if it's a battery powered small device, you actually use it on the plane. If it's pre-approved, they could do that as well. Expiratory relief, pressure relief is another way that can actually, increase comfort for the patient as well. And in Contour, I sound like I'm the guy who sells the pillow on Fox. Fox is one of the channels where, Mike Lindell. I just remembered his name. So this is not a Mike Lindell commercial. My pillow. This is the Contour pillow. CPAP pillow works, or basically all major brands. There's more than one brand of a Contour pillow out there. The point of it is that some of them are actually, you can actually mold them. Some of them come pre-molded. And it depends on the individual, what's most comfortable for them, etc. But there's some good data out there to say that it can lessen the severity of the OSA, but it can also increase the patient comfort, so that you can actually mold it. It's got that gel mold where if the circuit is kind of looping down, you can kind of cut, not literally cut out a trench, but you can make a depression in that so that the tubing is not kind of flopping in the breeze, etc. That the head position is optimal or nearly optimal, etc. So it's kind of a big deal, but it's one of those things that has to be trialed and sometimes trialed and error. Contour pillow a little more on it. So CPAP ease of use, the sleep comfort for all. Well, I don't say all. That's what they're really saying, but not all users, but for a greater percentage of users, thereby increasing compliance. Neck support and spine alignment, aligning the upper airway better, positioning it better, etc. Contour pillow also reduces mask leaks, or can do this, pressure on the mask on the face, bridge of the nose, etc., and overall mask discomfort. So there's some potential benefit there. What I say is the strategies I'm describing here should not be perceived as being mutually exclusive. So I talked about, the causes and they overlap and whatever, but it can be combining like an auto titrating with a humidifier, with a contour pillow, with but you get the idea, combining several strategies simultaneously. Some of the clinician patient interventions, so family social support, the bed partners acceptance. I put that there, but I'm really talking about it in the context of a lot of times the bed partner doesn't have a problem with it, okay? But the patient themselves perceive that they do, and it can be an issue as far as that goes. Suitable education and training on the equipment. Cognitive behavioral therapy, motivational enhancement therapy. I'll talk more about that, particularly in the context of claustrophobia. And rapid response to difficulties doesn't mean that they have to be fixed that second. But if someone has to wait 3 or 4 or 5 days for someone to get back to them because they're having an issue with their equipment, with their humidifier, with their mask, etc., the sense is that they're not supported in this endeavor. Okay. Even if the get back is, we are going to get you a humidifier, it's going to take a day or two to get you the humidifier, or we're going to get you a different mask, a different size, a different nasal pillows. We're going to get you nasal pillows, but it's going to take 2 days. If you got back to them right away and said they got to wait another day or two, that's not the end of the world. But if it's just this pregnant period of time goes by and no one's they feel unsupported. They're like, if it's not important to them, it can't be important to me. It should be, but we don't live in a perfect world. Initiation CPAP treatment should also include general advice on lifestyle, basically medical issues. Smoking should be stopped. Listen, I used to smoke, so I'm not saying it's an easy thing to do. It's not what I'm saying at all. But to the extent that the individual can, it can be good. There's also what's called overlap syndrome, which is individuals that have OSA and they have an element of chronic obstructive pulmonary disease. Okay. So, it could be helpful on some of the comorbid conditions as well. Alcohol should be avoided. That could be a toughie. People, it's just a part of their life. They may drink a glass of wine every other night or whatever. I think really what they're talking about is excessive alcohol should be avoided. Nocturnal sedatives or sleeping tablets, they really suppress the respiratory drive. It can be problematic in and of themselves. But the secondary, or not really secondary, but the associated issue is also if you're taking sedatives, you fall asleep, you're less apt to set the equipment up, set it up right to be compliant. Advice regarding body weight and its interaction with OSA should be provided if appropriate. There are case studies, not one or two, but there's case studies where at a minimum, if someone has a substantial, weight loss, whether it be on their own accord, totally diet and exercise, or through the use of, the Ozempic type medications, it will Wegovy is another one that's out there. That it could be transformational. That at least the severity of the obstructive sleep apnea and thereby the severity of the concomitant disorders that I described, a bit earlier, diabetes, heart disease, stroke, etc., that can be mitigated. It may be in some cases, in the case reports, in some cases, that issue can be resolved altogether, where their obstructive sleep apnea, their apnea hypopnea index is now, well less than 10, where they've had a demonstrable subjective and objective response just because of weight loss and maybe changing sleeping body position. Patients should be informed about the impact of sleeping position. So you can see that these also overlap as well. I don't mean to, by the way, I don't mean to give anybody the impression that, oh, you lose weight, you're not going to have OSA anymore. Because again, there are individuals who have no issue with weight. The BMI is 20 and they are not, they have OSA and whatever. But there is this very strong correlation between obstructive sleep apnea and BMI. Ongoing management, usage. So some of the suggested approximately, I'd like to say in a perfect world, but 7, 30, 60 days and approximately 12 months after treatment initiation, appropriate times. This is a suggestion. I don't mean to say, please, not that you guys are sitting there taking notes, but the point of it is there should be regular follow-up. And I will tell you, one size does not fit all. So some individuals, I think for some individuals, 7 days is way too long. Okay. You need to be following up with them a couple days later, a day or two later, and say, how are we doing with this? And they're the ones that may need the intensive intervention, on days 2, 3, 4, and 5 that I'll share with you in one of my later slides. So it's not, this is to really kind of throw out at you. It should be regular. Again, the frequency really depends, and that kind of is counter to what this slide suggests. But it's everybody's needs are different. They should have follow-up. It should be regular. It should be at intervals, and it should be tailored to that particular patient's needs. The provider should determine the patient's usage from again, the remote monitoring device, calculate the average hours use, et cetera, check the device and humidifier for satisfactory operation. Like I mentioned in the olden days, this really doesn't happen much anymore, except for individuals that own their equipment. Okay. That now they're not compliant. It sits, the filter's dirty, the sea monkey colony is in the humidifier, and you wouldn't put it on your dog type of deal. So that's a whole thing, a whole re-education thing that needs to actually happen. Reassessment, they may even need a new sleep study. Check the filters, the mask, the headgear for satisfactory condition, advise the patient, any faults, if you will, I'm using that term faults, but any opportunities for remediation and education and showing them, hey, listen, it could be a PIA to clean out your hose. But if you do it this particular way, and you let it, you do it literally in a kind of a shower type circumstance, okay, and you can clean it out with certain, brushes, and they have the ozone devices, but now those are really, those are falling out of vogue because of health reasons, if you will, different health reasons. But they are actually, if they're individuals educated on this, then it could do a lot in closing this gap between the patients who are compliant and the ones who are not compliant. Exposure. So coming back to this, the claustrophobia patients, and again, this is something that's been very deeply studied. But again, if this is the barrier, okay, if an alternative, less confining interface such as nasal pillows are not effective, so that would be one of your first lines. Try something along those lines. Then exposure therapy may be considered. Okay, I say maybe. Okay, I'm not saying that you personally should embrace this, but it's there's protocols that exist out there. So claustrophobia is composed of two core fears: fear of restriction the fear of suffocation. So notice this is not like one thing. You really, it can get complex because it's got multiple elements to it. Exposure therapy is indicated for individuals, or I'd say maybe indicated for individuals with sleep apnea who are unable to tolerate CPAP device due to anxiety reactions that are related to restriction and fear of suffocation. So contraindications, unstable psychiatric symptoms, inability to maintain therapeutic relationships. So, there are some patients that their anxiety, that the CPAP or BiPAP was just a trigger, but they have a severe, schizoaffective disorder, full blood schizophrenia, where the CPAP BiPAP may act as a trigger, okay, or just to exacerbate, not even just to cause it, but exacerbate it. That's a different thing. That's where the patient, for a moment, table the CPAP BiPAP, and you got to get that under control, and not you personally, but it would be to bring it to the attention of the prescribing physician. We need to do something else here. I can't even. Doesn't appear to be a claustrophobia thing. It appears to be something well beyond that. Okay, but in point of fact, most of the individuals who experience claustrophobia are not in that category of, they're not psychotic. They don't have severe psychiatric, disorders, things along those lines. They're individuals who have a fear. Some people, it's heights. Me, I'm not really that great on heights, to be honest with you. It may be, arachnophobia, spiders, or maybe that, whatever. But in some individuals, it's claustrophobia, and it's, really, that's really the issue. Other than that, they're just as normal as you or I or anybody else out there. So that's really making that distinction is critically important. Rationale for the intervention. We're talking about the claustrophobia intervention. Phobic individual confronts the feared object, the feared thing, situation, either through their imagination or real life, in vivo. The individual is supported in experiencing these fears, so they feel the fear in a gradual manner over time, and the anxiety will decrease. It's just doing it in a stepwise fashion. The effectiveness of exposure therapy stems from learning to tolerate and manage the anxiety without the need to escape. Throw the CPAP interface, across the room, whatever. Avoid the actual phobic stimulus. Exposure therapy increases the individual's perception of control over fear. So these are a lot of fancy words. What does Al mean by this? Okay, a little bit more granularity. So patient handout. So this would be an example. A lot of words on the slide. I don't really normally put this many words on, but to give you an idea. Okay, to give you an idea. So don't try to wear CPAP, during sleep until comfortable. So don't try to. We're not there yet. Okay, if your machine has a ramp feature, you may want to use the ramp feature. A lot of them auto titrating, whatever. To turn the CPAP is turn the flow on. Hold the mask over your nose. Didn't say put the headgear on. Practice breathing with the machine while you're awake. Okay. While you're doing this, keep, your mouth closed, breathe regularly through your nose. So your daytime, you're just kind of almost play acting there. Short periods of time, 1 to 5 minutes. It could be, by the way, 15 seconds. If that's the first start, so be it. Gradually build up to longer periods. Turn the CPAP airflow on. Okay. Wear the mask over your nose with the straps, on your head. It could actually be, by the way, putting it on your face initially without the straps and then later doing that. Practice breathing with CPAP. Wear the CPAP longer periods until you can actually tolerate it 15 to 20 seconds. But they're really saying this one kind of during the day. Number 3 is also during the day, but it's now try laying down or sitting in your recliner, but preferably, in a similar position to when you're sleeping. Not important whether you fall asleep or not. The goal is to rest comfortably in your bed with the CPAP on. Wear the CPAP at night when you go to sleep. If you experience claustrophobia or uncomfortable feelings, go to your previous step. So what they actually would say would be this. So when you get to the point where you're using it at night, they would say, yeah, you can rip it off anytime. You can take this off anytime. But likewise, see if you can leave it on for 5 minutes. See if you can. And then take it off, turn the machine off, go to sleep. But the next night, you're not off the hook. Next night, you're going to try it, and you're going to try it for 6 or 7 or 8 or 10 minutes. Okay, yeah, take it off. But it's a gradual thing. And by the way, if you can't do it for 5 minutes, you do it for 1 minute, then you start over 1 minute. Next night, it's 2 minutes. So it's tailored to everybody, but it's gradually building up. This is not a panacea, but I will tell you, this approach has been shown to work with a significant percentage of people that have this complaint of claustrophobia with a CPAP interface. Now, again, time really kind of precludes us from drilling down a lot more on this, but I will tell you what we did. It wasn't a claustrophobia thing, but what we found was that 30 years ago, and again, there wasn't auto titrating, but we had ramp features. We had some decent masks. They weren't as good as some of the masks today, but we found that our compliance rate was somewhere in the range of 40–50%. Maybe it was a little north of 50 sometimes. I will tell you that because of some of the medical malpractice cases I've been involved in, as far as consulting in, that it's been studied very widely, including by the Centers for Medicare and Medicaid Services. And compliance rates or non-compliance rates are as high as well over 50%, 70% in some cases. Okay, so it's widely recognized that getting patients to be compliant, whether they be at home or in the hospital using their home CPAP, BiPAP, okay, that compliance is an issue. So we also recognized that if we could, I don't mean literally trick the patients into using full disclosure, folks. So it would be like, okay, so optimize, make sure you have the best interface that you can. Start off with humidification. Back then, it's almost the default now. Ramp now would be auto titrating, a proper education, proper follow-up. So you've done, your protocol includes all that, but basically asking the patient to try the CPAP or BiPAP for 5 minutes on the first night. Literally, time yourself, 5 minutes. By the way, if you fall asleep, but this is a patient who's having difficulty. Say at 5 minutes and 2 seconds, take it off, turn it off, if you don't tolerate it. The next night, you got to try 10. If 10 doesn't work for you, you got to try something more than 5 and try in earnest. Not this, oh, just a little bit uncomfortable. I just ordered my DoorDash and I ate my DoorDash and this doesn't work. No. This is earnestly try and saying to them, listen, it's important that you get compliant with this eventually. Because remember all those comorbidities that we talk about, they're real. So you get it. Getting them up to 10 minutes. Again, I will tell you that upwards of 3/4 of the people, from less than half, 3/4 of the people by a week, 5 to 7, 8 days, when we would follow up with them. So it wasn't following up at day 3, 7, 30, whatever I said before. It was following up frequently. The ones that were actually tough to get them to be compliant is by 5, 6, 7, 8, 8th night is they would then, 75% of them would be like, oh, I thought I was ripping it off after 15 minutes, and it was actually 6 hours. It was a substantial amount of time. Okay. And then you say, okay, so tonight just try it again, but after 15 minutes or 20 minutes, take it off. And sometimes they took it off after 15, 20 minutes. But then the next night, it would be another one of those nights where it was 5 hours, and I thought it was 15 minutes, it was 5 hours. And then you get them to use it enough, and then you start debriefing, how do you feel versus before? And again, it wasn't 100%, but it was 3/4 of them was like that morning headache. And you get into that point, and you continue tweaking with humidification, the things that I just mentioned above there, and you can get some serious headway, and improve the patient's quality of life, but improve their productivity not just professionally, but also their involvement with the family and friend dynamic, and they're using health services less, they're healthier. That's really what I'm trying to say. So it's good on all fronts there. So just something to kind of think about. It wasn't an evidence-based thing, but it was just something to kind of keep in mind. Take-home points. So untreated OSA, obstructive sleep apnea, has serious consequences, some of which we've only learned about in the past 20 years or so. There's also these individual issues. There's also those that relate to society. Given the nature of basic positive airway pressure involving blowing air, in some cases at greater than 100 liters per minute into a patient's face, airway, no surprise that many barriers exist. However, there are definitely strategies which can offset many of these barriers and enhance patients' compliance. CMS, I really believe CMS reimbursement will continue to be a challenge. It's just the reality of I do another lecture on comparative healthcare systems. We have the most expensive healthcare system in the world, and by a large margin, and our outcomes are not. Many other developed countries have better outcomes than we do. So we'll continue to try to kind of, peck away at reducing our expenditures, which may mean that there's less resources out there for, follow-up, et cetera. Such a challenge. I don't have all the answers. However, overcoming these barriers requires careful planning and commitment to success by multiple stakeholders, including patients and clinicians who serve them. Okay. I firmly believe that we talk in the world of AI, and it's not going to be a decade. It'll be, we're already using AI to determine patients who, are at risk for diabetes, or for, interpreting test results, including X-rays and other imaging studies, et cetera. For, believe it or not, managing, ventilators. Now, I'm not saying they're doing it independently. Okay. It's not. It's still, the United States FDA says that there needs to be a person, a licensed and trained person that's managing the patient on the ventilator. Okay. In Europe, they allow changes to be made by software. Okay. Point of it is that it's not going to be so long until AI can identify patients who are at high risk for being non-compliant before they're set up, and to come up with algorithms that will help them be more compliant and monitor them and work with them, et cetera, through machine learning. So that's not the purpose of this presentation, but I'm sure that that's on the horizon. Again, some selected references, including the Spriggs polysomnography. It is to sleep medicine, like I said, that Egan's is to respiratory care, and some other resources that are here as well. With that, I want to thank you guys very much for joining us today. Hopefully you got something out of this presentation. I know we have Sherry, who's going to be joining us from Canada. She's actually joined us, but she's going to be giving, I believe, the next two presentations, and then Terry will wind things up as well. So this is what I'm going to do. I am going to conclude this, but I'm going to remind you guys to go into the Q&A and to check in.